The following podcast is part of a certified educational activity titled Refining Treatment Models for Biliary Tract Cancer Aligning Practice with Rapidly Evolving Evidence on Immunotherapy and Targeted Platforms. Access the entire activity and complete the post-test at peerview.com/VZA860. Downloadable slides and practice aids are also available.
Welcome to this PeerView educational program. And I also would like to welcome you with my two colleagues, Teresa Macaruda from Barcelona in Spain and James Harding from New York. And I think we will have a very interesting and hopefully interactive discussion with you on the treatment of cholangiocarcinoma. So what we would like to do tonight with you is to really discuss the changing landscape in cholangiocarcinoma and comparing to the days when I at least started, there were not really too many options. And today there's still a lot to do, but we do have a lot of options, and molecular testing needs to be done very early on. And these are all points we would like to discuss with you. And also the introduction of immunotherapy was also successful in cholangiocarcinomas as in several other tumor types. And we will go into all the details and also how we can and should manage the side effects. So I will give you first a little bit introduction on where we are and what is the outcome for patients with cholangiocarcinoma. First of all, it's important when we talk about cholangiocarcinomas, there are different types: intrahepatic, extrahepatic, and also gallbladder cancer. So far, we did not really distinguish them in clinical practice because they responded very similarly to the treatment we apply, specifically chemotherapy. I think when we look at the newer data, we do get some ideas that maybe not all tumors respond the same. And for the targeted therapies, it's also important because some of the alterations we find specifically in intrahepatic, like FGFR2 fusions and IDH1 mutations, while others are slightly more frequent in extrahepatic, like KRAS G12D or HER2 alterations, for example. Overall, I think we have to acknowledge that the incidence of cholangiocarcinomas is rising. We are not completely sure why. Maybe related to the fact that in some of these patients we do see chronic liver diseases, such as viral diseases, but also non-viral diseases related to obesity or alcohol consumption. And we know that this can also contribute to a higher risk of cholangiocarcinoma. So overall, the incidence rate is rising, and so far it's still a very deadly disease. So there's a lot to do for us. This is, I think, is also highlighted when you look at the survival data, which really have not much changed over time, and maybe there are also some prognostic implications of the intra and extrahepatic cholangiocarcinomas I have mentioned. What is also important is that, first of all, for many years we did not have too many treatments available, but also patients were not able to receive too many lines of therapy. As you can see here, this was a real-world cohort of patients treated with systemic therapies, and unfortunately the majority of our patients require systemic therapies. And what you can clearly see, gemcitabine-based chemotherapy is kind of the backbone of what we are using, sometimes also 5-FU-based. But when we take this as 100%, you can see it to second line. The majority of patients does not make it even to second line. And even in experienced centers, only around 50% of patients are treated in second line. And the numbers are even getting smaller when we think about the third or even further line. So it is a very aggressive tumor, which requires really intensive treatment. And many of these patients only treated for 1 or 2 lines of therapy. So what are the shortcomings? And I think there are definitely not only shortcomings, but also a lot of opportunities. So one shortcoming, what I do not really see as a shortcoming, is the point that still not too many patients are included in clinical trials. I think what we can also highlight is that we do have a lot of clinical trials available today. And I think that was different like 10, 15 years ago when there were hardly any trials in cholangiocarcinoma. So we have more. I still think we need to do more, but specifically for the targeted therapies that are in development at the moment, like new targets, NTEP deletions, and also the KRAS inhibitors. What I realized, and maybe you can also comment on that many of the pharmaceutical companies are still focused on the large tumor types, right? Lung cancer, pancreatic cancer, and cholangio is more like, okay, let's see what happens with the other tumor first, and then we may go to cholangiocarcinoma. And I think we all need to push hard that cholangiocarcinomas are really very early on included in these clinical trials to really improve outcome here. And molecular profiling is really of utmost importance in cholangiocarcinoma. And this is the second point we would like to address. What we have learned is that there's really a striking inter- and intratumoral heterogeneity, which maybe also contributes to this aggressive tumor. And what we have learned that there are a lot of genetic alterations for which we have already targeted therapies available. Many of these alterations are in single-digit frequency, so HER2 alterations in maybe 2, 3, 4, or 5% of cases, also depending whether intrahepatic or extrahepatic cholangiocarcinomas. So here broad molecular testing is important, and this is something that is not yet completely implemented in clinical practice. Yeah, so more recent data suggests that still only around 50% of cases get molecular testing, and I think this is definitely something we need to improve, and all national and international guidelines today clearly recommend that all patients as early as possible, and we can discuss whether it's already at the time of diagnosis or latest at the time when we start systemic therapy, should receive molecular testing. And the molecular testing is not very easy, and we will discuss this later in this session. So we need to really pay a lot of attention to which tests are used. And I think here it's really important that we have a close interaction between the clinicians, but also the molecular pathologist. I think it would be really bad if we perform testing, but then we are using like the wrong test, which, for example, does not detect FGFR2 fusions. That would be really devastating and missed opportunities for our patients. So it's important that we understand which tests are used and that we are using tests that are really detect all the alterations which are of clinical relevance at this point. And of course, we would like to involve our patients into the whole process. I think we have really made a lot of progress in recent years. We need to have a very close interaction. What we are seeing also for clinical trials, that we have these lay summaries, which I think are very helpful. Here at ASCO, we have also seen it in the presentation, that the presentation ends with a lay summary. And I think this is really important that patients really better understand why we make certain decisions, and these decisions should be made together. And it definitely will help us to bring patients through the treatment. And of course, for this, we also would like to highlight the work of these patient centered organizations like the Cholangiocarcinoma Foundation, for example, which have really done a tremendous work in recent years to provide education and resources to patients. And here are just a few of them. I think you should go to the website and you can see what you find. You can, I think, really critical, important resources like the patient registries, finding a specialist, second opinion is really important, and also to find about clinical trials in this disease. So coming to the end of the introduction, in the first part of today, of this meeting, we will focus on immunotherapy. And in the second part, we will go more into the discussion of targeted therapies in cholangiocarcinoma. And with this, I would like to hand over to Teresa, who will give us like an update on recent development for immunotherapy in BTC.
So thank you very much, Anne, for the introduction. So now, as you said, let's review the data that we have today that justify that we change our standard of care. And today, our patients with advanced BTC are treated with chemotherapy and immunotherapy as a new standard therapy. So let's start with a clinical case. This is a patient of 60 years old with a history of abdominal pain and also an intentional weight loss And this patient with the different imaging reveals that presented a metastatic intrahepatic cholangiocarcinoma. The patient maintained a good performance status, only PS1 justified for this abdominal pain and well lost, and no relevant biomarkers were detected. So let's see that we will come back to this case later. So first of all, we have different mechanisms to increase the immune system of our patients in order to fight against tumor cells. The most used are the immunocheckpoint inhibitors, mainly in BTC, as we will see later. The most important ones are the anti-PD-1, for example, pembrolizumab, or the anti-PD-L1, for example, durvalumab. But we have other potential methods that are less advanced in the development in BTC, but maybe one day can play an important role, for example, agonist antibodies like CD27 agonist or CD40 agonist, or also, for example, CAR T-cells or other mechanism of action. So a lot of here, a lot of new treatment options, potential treatment options in the near future. So what says the NCCN guidelines how we have to treat our patients? So as you can see here, the recommended first-line treatment options for our patients with a category 1 is immunotherapy in combination with gemcitabine and cisplatin, durvalumab or pembrolizumab. It is also mentioned that it's an option for those patients with MSI high to treat those patients with pembrolizumab, and also it is mentioned that patients with high TMB can be treated with a combination of nivolumab and ipilimumab with less evidence. And also, what about the further lines, not in first line? Well, it says that if a patient has not been treated previously with checkpoint inhibitors, we can consider to treat those patients with durvalumab or pembrolizumab and chemotherapy in further lines. Or also, again, if our patient is an MSI high, we can consider pembrolizumab or dostarlimab, again, with less evidence, or for TMB high tumors, we can consider in further lines nivolumab plus ipilimumab or pembrolizumab. So these are the NCCN guides recommendations. And here we will review now the two pivotal clinical trials that justify our standard of care today. The first one is the TOPAZ-1 trial. It was the first trial that presented the positive results with immunotherapy. And in fact, this was the first positive clinical trial, phase 3 clinical trial, after the ABC02 trial that was published 12 years before this trial. In 2022, it was presented and then published, the TOPAZ-1 trial, that include patients with advanced biliary tract cancer, gallbladder and cholangiocarcinoma patients, and those patients were randomized to be treated with durvalumab, gemcitabine, and cisplatin for 6 months, and then durvalumab as a maintenance strategy, or the same strategy but with placebo. Primary endpoint of this trial, overall survival. And as you know, this is a positive trial for its primary endpoint with a hazard ratio of 0.8. And here it is very interesting data that it was published recently, last week or 10 days ago, in Journal Hepatology, that is the 3 years overall survival in this trial. And for me, only to show this data, it's very, very interesting. Why? Because we don't have these patients alive at 3 years in the ABC02 trial, so really there's an improvement here. And as you can see, 14% of the patients treated in the durvalumab arm were alive at 3 years. This is impressive for me in this poor prognosis population, and 6.9% of the patients in the placebo arm were alive at 3 years. Also, interestingly, with a longer follow-up, we can see that this hazard ratio of 0.8 improved to 0.74. And also very interesting data that was published in this publication, and you can see here how you can see the 3 years overall survival rate depending on the response of the patient. And as you can imagine, patients with partial response or complete response presented higher percentage of patients alive at 3 years. In fact, it's incredible to see 31% of the patients alive at 3 years if the patients presented a partial response or complete response in the durvalumab arm, compared with 15.6% in the placebo arm. Then less difference in the stable disease group, 9.8% of patients alive at 3 years in durvalumab arm and 5.1% in the placebo arm, and there was no difference in the patients that achieved a progressive disease as a best response. And also regarding side effects, you can see that the grade 3 and 4 adverse events were really similar between both treatment arms. Mainly the toxicity that is reported in the TOPAZ-1 trial is related with the chemotherapy and mainly is hematological toxicity. And here we have the second pivotal trial, that is a KEYNOTE-3 and 966 trial. And as you know, this trial was published 1 year later, presented and published 1 year later, and the same population, patients with advanced BTC, were randomized to be treated with pembrolizumab, gemcitabine, and cisplatin, but here only cisplatin was stopped at 6 months, and then patients continued with pembrolizumab for a maximum of 35 cycles, and then you can continue with gemcitabine or not, and this was the investigator choice, but there was a possibility to continue with gemcitabine. And then we have the same strategy with placebo, and again the primary endpoint, overall survival. And this is again a positive trial, different curves, but positive trial with a hazard ratio of 0.86. And also in the last ASCO meeting, Richard Finn presented us the 3 years overall survival, and again very consistent results with the TOPAZ-1 trial. As you can see here, patients treated with pembrolizumab presented a 3 years overall survival of 15% compared with 11% in the placebo arm. Probably you can see here that the difference is less, that we have less differences between both arms because the patients in the control arm, an important group of patients were treated with pembrolizumab and gemcitabine, not only with gemcitabine and placebo, and probably this control arm is better than the TOPAZ-1 control arm. And here you have again the adverse events in the KEYNOTE trial, and as you can see here, very consistent with the TOPAZ trial. Grade 3 and 4 adverse events similar between both arms, and again mainly related with toxicity with chemotherapy. And what's next? So what's in the near future regarding immunotherapy and BTC? I want to highlight this trial. I think it's a very interesting trial that is a tourmaline study that tests the efficacy and the safety of durvalumab in combination with other chemotherapy strategies. And that's important. Why? Because not all our patients are fit enough to be treated with a combination of immunotherapy, cisplatin, and gemcitabine. So what happens if I have to treat a patient only with gemcitabine or gemcitabine and cisplatin, but with an ECOG2 or with gemcitabine oxaliplatin, gem carboplatin, or other combinations? And this tourmaline trial will generate this data and will help us to treat our patients, if it's necessary, with different chemotherapy schedules. And then we have other clinical trials ongoing with immunotherapy in BTC. I want to highlight the first one, that is this trial that is testing the Artemide trial, that is a randomized phase 3 trial that is testing or is trying to see if we can translate the efficacy of immunotherapy in BTC, in advanced BTC, to the adjuvant setting. And here the patients, after resection of BTC tumor, patients are randomized to be treated to chemotherapy, adjuvant chemotherapy in investigator choice, plus rilvegostomig, that is a bispecific antibody against TIGIT and PD-1, or only chemotherapy plus placebo. I think it will be very interesting. The primary endpoint is relapse-free survival, and in some years we will see if we can incorporate the immunotherapy also in this adjuvant setting. We have other strategies, and some of these strategies also in the adjuvant setting or even in the neoadjuvant setting in the smaller clinical trials. So let's see how we can improve the data that we have today. And also what it is important is through that in the pivotal trials, the incidence of immune-mediated adverse events, especially the grade 3 or 4, that are the ones that are really of interest for us, are really in a low incidence. However, we know that when we treat a patient with immunotherapy, we can have any organ affected, and we can have toxicity at any moment of the treatment. So we can have the toxicity at the beginning of the treatment, or we can have the toxicity during the treatment. And also importantly, when we have a combination of different immunotherapy strategies, the incidence of adverse events, immune-related adverse events, increase. When you can see here that the most common immune-related adverse events in general with immunotherapy is skin changes and also hypothyroidism. So fortunately, these are side effects that in general we can manage pretty well with a therapy. how we have to manage the side effects in general. So depending on the grade, of course, if we have a grade 1 toxicity, we can continue with the checkpoint inhibitor. We have to closely monitor our patient, but we can continue with the treatment. If our patient presented a grade 2 immunological toxicity, we have to halt the checkpoint inhibitor until the patient recovered to grade 1 or lower grade 0 toxicity, and we can administer some corticoids to our patient in order to improve the toxicity. For example, we can use 0.5, 1 milligrams per kilo per day of prednisone, or even higher doses, for example, with side effects like the colitis. And also, what happens if we have a grade 3 toxicity? Of course, we have to stop the checkpoint inhibitors, and then we have to treat the patients with higher dose of corticoids. And then once the patient recovered from the toxicity, I think we have to individualize depending on the type of toxicity if we can introduce again the immunotherapy or not, depending of the type of toxicity that the patient presented. Finally, of course, if we have a grade 4 toxicity, we have to stop checkpoint inhibitors and discontinue it, and we cannot reintroduce the immunotherapy. With this, we come back to our patient. So I remind you that this is a patient, 60 years old patient with a good performance status, with an stage 4 intrahepatic cholangiocarcinoma. So my question here is, Arne in Toronto, how do you treat this patient next Monday in your clinic?
Yeah, so in the first-line setting, I think it's really not so difficult because I think the data you have just presented are really convincing. I mean, I think we all would hope for more. I mean, more efficacy, longer duration of response, deeper responses. But I think we have now 2 large phase 3 studies which have clearly shown checkpoint inhibitors are effective, right? And I agree with you that between durvalumab and pembrolizumab, there's probably not so much of difference in terms of efficacy and toxicity. So I think the really majority of our patients are treated with gemcitabine durva. If you don't have any contraindications, of course, right? But in a patient as depicted here, with tumor symptoms, we would like to see responses, and I think we should take and use the most effective therapy. And for me, this would be gemcitabine plus a checkpoint inhibitor.
But James, when you visit the patient, your first visit, do you explain 6 months of chemo, or do you explain chemo anti-progression?
Yeah, that's a great question because obviously had 2 studies, one where chemotherapy stopped after 6 months, the other where you continued gemcitabine. And so I do go over the 2 regimens. I do go over that. Obviously, you can't compare these studies, but the outcomes seem quite similar. I do discuss that throughout the treatment. Some that are quite fit, I may continue the systemic chemotherapy, tolerating it well. Others that seem to have a hard time would move to an immunotherapy maintenance. So that's been my approach. I think it's a shared decision in this setting where you don't have really comparative data. What do you do?
Yeah, I think it's a very good point, right? And it really depends on the patient, right? Some really are looking for a chemo break, I think, right? And they do much better without chemotherapy. They have time to recover. We do see this cumulative toxicity. And I think we do see also more and more real-world data supporting this approach, right? That probably after 6 months, the benefit of chemo is probably more limited and we have more toxicity. Yes? And therefore, with the introduction of the 2 trials, I have to admit, I mean, in the majority of my patients, I go to maintenance, but there are also some patients which prefer to continue on chemo. So it's really a shared decision.
And also a question of toxicity. There are some patients with a lot of hematological toxicity, and you want to preserve a little bit this bone marrow in order to treat the patient in second line with better treatment. No?
Maybe one question. So if they progress on immunotherapy, so would you go to second line or would you re-challenge with
more gemcitabine? Yeah. So I don't think we have an answer formally, though in certain instances where the progression has been quite rapid on first-line immunotherapy, I do just consider resuming gemcitabine and cisplatin if it was well tolerated. And anecdotally, I've seen stabilization and even sometimes response because I feel that this was the dominant factor in the disease progression.
I think the time is important because it's not the same, of course, if in the first CT scan that you are with the maintenance strategy, patient progress, but also it's important if the patient presented some target therapy that that can respond very.
Correct.
And if the patient don't have any target therapies that you have to treat the patient with 5-FU, that that it's maybe you try to retreat the patient with cisplatin and gemcitabine. No? Yeah.
So what did you do with your patient?
In general, I tend to use immunotherapy and gemcitabine altogether 6 months, and then maintenance with immunotherapy. In general, I explain this to my patients, and I have to say you that they love this strategy: 6 months of chemo. So only a period of time, not forever. No, without can concrete the time. No, so I think that's something that the patient also appreciate.
Okay, so now I think we have covered immunotherapy in death, and now we would like to go to the targeted therapies. And this is definitely getting a little bit more complicated because we do have a lot of different targets, and we would like to provide you a brief overview. And to start with and to set the scene, James Harding, so what are the most common genetic alterations in
Sure. So this will be brief to introduce my colleagues for the other portions. And so precision oncology clearly has entered heavily into the scope of the treatment of biliary tract cancers. And this is just a timeline illustrating, the first positive study, the ABC-02, which established gemcitabine and cisplatin as really a backbone and the treatment for many years. And as we just heard, the advent of immunotherapy in combination with that has further improved outcome. But what has also occurred during this time period is molecular profiling of biliary tract cancers has revealed that a high proportion of them are with tumors that have driver mutations which can be targeted. It's up to 40 to 50% of intrahepatic cholangio, maybe 20+% for extrahepatic, up to 30% for gallbladder cancer. And the first breakthrough really were in agnostic settings with MSI high tumors and NTRK fusions, but then we saw quickly very specific studies in FGFR, mutated cholangio, IDH1 driven cholangios, and others, which has really provided additional second line and hopefully soon first line options for patients. The current spectrum of targetable alterations in intrahepatic cholangiocarcinoma is seen here. Some of these are established targets, which we'll talk about at length tonight, including FGFR2 fusions, IDH1 mutations, HER2 amplification, and others. I'd also note that on the slide we can add more. You see MTAP loss. There's a new class of drugs looking at targeting these, as well as some subset of RAS alterations and MDM2 amplifications. So it's a very active field where there's a lot to be learned and a lot of potential to impact treatment. And so at the present time, I think the most critical point is really there are the targets and we really have to assess for them. And this is just lifted really from NCCN recommendations, and this is echoed in most global guidelines now, that really you need to establish assays to test for these mutations and profile patients in a timely fashion to align them with now FDA approved or recommended regimens. And I'll just lend my last slide before we talk about IDH1, FGFR, and HER2 with the promises and perils of precision medicine. So we heard earlier, detection is critical. So, our own experience at Memorial, probably 20% of patients may not get genotyped for some reason. Either it's because there was insufficient tissue, either it was because the tissue failed to genotype. So you really have to have novel solutions to think about that. We'll hear about cell-free DNA, the use potentially of repeat biopsies when needed for certain molecular alterations, immunohistochemistry. Another issue, which is true, it's provider and physician and patient knowledge. These are complicated alterations. They're not that simple. My favorite one is always RAF. So you have class 1 RAF alterations. They're activating. You can target them with a RAF MEK inhibition. You can have class 2 or 3 where it's not so simple and they're very similar. And so the solutions really are knowledge bases, which are built into many of the molecular profiling now, guidelines from societies, molecular tumor boards, and we and others use automated notification to our whole stream of providers when we identify a mutation at Memorial. The other issue is the infrequent nature of some of these mutations, which means we have to be thoughtful about experimental designs, and we'll hear that throughout some of the talks. And I think the defining factor is the fact that resistance develops in many of these approaches. And so we'll hear, I think, very nicely with FGFR, the story of how by understanding resistance, we may be able to improve outcome. And then finally, the majority of patients have an undruggable genome, but that may be changing with the advance of novel therapeutics and combinations. So thank you for that, and I'll pass it back to you.
Thank you. So now we will review in the next 10 minutes IDH1 as a target in intrahepatic cholangiocarcinoma. First of all, we will start again with a clinical case. This is a patient, 65 years old lady with unresectable cholangiocarcinoma that was treated in a frontline therapy with chemotherapy plus immunotherapy, but unfortunately progressed after 6 months of therapy. So the patient would like to discuss the next step to manage their metastatic disease, and the patient undergoes an NGS testing. Ideally, the NGS have to be done at the beginning, before to start the first line, and we have to receive the results during the first line, just in order to be prepared for the second line. But in this case, the patient undergoes NGS testing, and we receive the results that the patient presented an IDH1 mutation. So let's start. What says the NCCN guidelines? How we have to treat the patients with an IDH1 mutation. So here the recommendation, and in fact this is the only category 1 recommendation for target therapy in BTC, that is ivosidenib in those patients with cholangiocarcinoma and IDH1 mutations. Why? This is based in the Clarity trial that in fact is the only positive randomized phase 3 clinical trial with a target therapy in cholangiocarcinoma. And in this trial, we include patients with cholangiocarcinoma and IDH1 mutations in second or in third line. And those patients were randomized 2-to-1 to be treated with ivosidenib or placebo. And the crossover was allowed. In fact, it was the patient advocacy group who pushed us for include this crossover in the design of this trial. And this was accepted for FDA, and for this reason, the primary endpoint of that trial was centrally reviewed progression-free survival. So here you have the results of the trial. When you see the median PFS, this is the primary endpoint of the trial. It's not so impressive, 2.7 months compared with 1.4 months, but probably it reflects better the activity of ivosidenib, the 6-month and 12-month PFS. When you see the 6-month PFS is 32% in the ivosidenib arm, and is 0 in the control arm, placebo arm, and at 1 year, 22% of the patients were still without progression in the ivosidenib arm, compared with 0% in the control arm. So probably here we have more the idea how those patients has a benefit from this treatment. Then after that, when we see the overall survival, there was not a statistically significant difference between both arms. That's a normal, or we can expect this, because 70% of the patients did the crossover from the placebo to ivosidenib at progression. So for this reason, it's very difficult to have an impact in overall survival. When we apply this method to adjust the results for the crossover, you have a hazard ratio of 0.49, so positive results. And what's next in IDH1 as a target in BTC? We have here 2 clinical trials. The first one in the middle of the slide, you can see this is a clinical trial. There's some publications that suggest us that the tumors with IDH1 mutation can be cold tumors compared with the rest of the intrahepatic cholangiocarcinoma, but when we treat these tumors with ivosidenib, we have an increased immune infiltration. For this reason, it makes a lot of sense. This clinical trial, phase 1 big clinical trial that combined ivosidenib plus a PD-L1 inhibitor and a CTLA-4 inhibitor. And you have here the combination of ivosidenib, ipilimumab, and nivolumab. And this was tested beyond first line. Unfortunately, in this trial, it's now on hold due to the toxicity that presented this combination, mainly a rash, skin toxicity, but it's a very, very interesting strategy. And the other clinical trial that it will be presented as a poster, like a trial in progress tomorrow morning. And this is a very interesting strategy, is to try to move to first line. Why, if we have a patient with IDH1 mutation, why we cannot treat this patient in first line with ivosidenib, gemcitabine, cisplatin, and durvalumab, or the same strategy without ivosidenib. And this is this clinical trial. So for now, today is a phase 1b clinical trial, so with single arm trial that tests this strategy, ivosidenib, cisplatin, gemcitabine, and durvalumab. So let's see if this change in some years the standard of care. So regarding the toxicity, ivosidenib is very, very well tolerated. In fact, you can see here that the main grade 3 adverse events or higher are ascites, and sometimes probably can be also a role with the tumor, the tumor that is in place. And also when you see here the adverse events leading dose reduction and interruption, it's only 4%. And when you see the adverse events leading to stop drug discontinuation, it's only 7% in the ivosidenib arm in the Clarity trial and 8% in the placebo arm. So really it's not frequent, and that means that it's really, really well tolerated drug. And that means that probably we can combine with other strategies. And also we have other clinical trials ongoing. It is described in some publications that maybe this population with IDH1 mutations have more HRD alterations, and for this reason there's some clinical trials with the strategy to treat those patients with some PARP inhibition, PARP inhibitors. And I want to also highlight this data. This is the data of other IDH1 inhibitor, that is this LY 3410738. This is a potent IDH1 inhibitor that it was tested in combination with cisplatin and gemcitabine in first line in cholangiocarcinoma patients, few number of patients, but you can see here that the response rate with this strategy, it was really high, 46%, and this is higher than we expected only with chemotherapy. So it seems that this strategy to go to first line in combination with the standard of care, and today of care, of course, we have to add the immunotherapy, but it seems that it can be a strategy that can be really active. So let's see what happened with the clinical trial that is ongoing. And with this, our clinical case. So here we have this patient that progressed in 6 months to first-line therapy and then presented this IDH1 mutation. So James, what happened? How we can treat this patient?
Right.
We can go directly to target therapy?
Yeah, so I think the options potentially available to you would be ivosidenib. There are also cytotoxics that could be employed, but given the Clarity study, I do think it's reasonable to do that. And although the change in median is not very much, the hazard ratio is very low, and there's a subset of patients that will have cytostatic disease control for an extended period of time, oral medicine, minimal toxicity. I've had patients on ivosidenib for years. This subset is quite beneficial. I also think it's important, since it is oral and potentially you can have digestive issues and absorption issues, I would prefer a targeted therapeutic over cytotoxic in this setting, and I would use ivosidenib.
In fact, you mentioned that there's this 16% of the patients treated in the Clarity trial that were treated for more than 1 year with ivosidenib. What we don't know today is how to identify those patients. Now, all of them presented IDH1 mutation, but only this 16% were treated for this in second or third line, 1 year of ivosidenib, more than 1 year. It's really an incredible data, but it's this selected group of patients. No? So for you, do you treat patients with IDH1 mutation with ivosidenib in third line, and you treat chemotherapy in second line, or you treat always target therapy in second line?
So I can hardly imagine like a scenario where I would not use the targeted therapy in second line. So as I've shown in the first slide, the number of patients that really make it to third line is really low, right? I mean, we do see an enrichment, of course. Patients that are in second line are, of course, also likely to make it to third line. But I would not take any risk, and I would really try to use the targeted therapies as early as possible. I personally think, since we are dealing with secondary resistance, it may be better to start when also the tumor burden is not too high. So I would definitely go for second line. The question is, would you go for first line?
If you have a clinical trial, yes. I would try to include the patient in the clinical trial. Otherwise, I think today we don't have the data to use this in first line, unfortunately.
I agree. So at the moment, it's probably not the time for first line. But there was an interesting question, and we only have one question. I wonder whether nobody wants to win the $50, right? So you have to send questions and ask questions. And one question I just received was, should we be testing for all potentially targetable mutations at baseline? Yeah, or can you immediately initiate therapy while additional testing is done? Which I think is a fair question. I mean, I think we are moving forward that we get the results for molecular testing faster. But the question is, should we wait for the results, or would you initiate like Gemcis Durva first and then you get a result after 4 or 6 weeks? How would this change your decision?
I think if you don't have a clinical trial in first line, that in this case we have to wait the results. I think in first line, because there's no indication of target therapy, you can start cisgem immunotherapy. Some patients cannot wait for the results of the NGS. That sometimes can take 1 month or even more in some institutions. So, but I think it's important to receive the results during the first line, because you have to be prepared for the second line. Sometimes it's difficult.
Do you use both genotyping of the tumor and cell-free DNA, or how do you approach this?
For us in our institution, and I think this is the guidelines in Europe, is the tissue is the standard. Why? Especially for because the sensitivity of the techniques in the tissue are better for the fusions. And if we don't have tissue, because it's not possible to biopsy the patients, we go for liquid. This is our strategy.
Yeah, same for us. So I think that's really a valuable resource now, and we will discuss it in more detail when we talk about the FGFR2 fusions, to use liquid biopsies, because sometimes it's really difficult to get sufficient tissue for sequencing. And again, I mean, I think it's important to do the testing as early as possible, as you said, right? I mean, we need to know our options, what we can use in second line. And we have also seen a couple of trials which have been started in first line and which failed their recruitment, right? For the FGFR2 fusions, 3 phase 3 studies were initiated, and none of them really finished recruitment. And I think we changed now a little bit so that we allow treatment with Gemcis standard of care treatment, and once we have the druggable alterations, we can add it on later on when we have first line trials, right? But this is clinical trials, and in clinical practice we still do it in second line. Yeah. And there's another question for you, back to the immunotherapy very briefly. So you mentioned you would treat Gemcis and immunotherapy, but the question is, how do you choose between Durva and Pembro?
That's a very good question. We tend to use more Durva because we start with Durva. That's like this. But also in Europe, sometimes it's a question of also the price, and sometimes it's our pharmacies who tell us what we can use. Unfortunately, it's like this. So sometimes we have to use Pembro because the price is cheaper in Europe today. But I think we don't have to decide is if we want to use 6 months Durva, if I want to use continued treatment Pembro, because I think this is not the situation. I think you can use both with both strategies.
I agree with
and you?
Yeah, I think either is acceptable, and there's no real way. I don't see a strong difference between them. So,
okay, so back to targeted therapies, and now we want to discuss with you FGFR2 fusions, and they are really interesting. I think it's hard to say which alteration is most complicated. I tend to think IDH1 because it's so diverse and you don't really know what it's doing and how much is the tumor really depending on mutant IDH1. I think it's a little bit easier for FGFR because we know that once you have a genetic alteration in FGFR, the tumor usually tends to depend on these alterations, and you will see the response rate in a minute. So once we target FGFR2 fusions in cholangiocarcinoma, usually we do see responses in contrast to what we have just learned about IDH1 mutations. The difficult part about FGFR is really to understand what are we talking about. Yeah, is it overexpression? Is it mutation? Is it fusions? So, and this I think we need to distinguish because everything can occur. We can even have amplifications, and we know that they tend to respond a little bit different to FGFR inhibition. And when we talk about FGFR2 in cholangiocarcinoma, in the majority of cases we talk about FGFR2 fusions because we know that these are really strong drivers. Also in preclinical models, they lead to tumor formation. And the tumors tend to depend on the signaling pathway. And as you can see here, this is also connected to the RAS-MEK pathway. So it's a strong driver for tumor cells. And if we disrupt this activation, we take a lot of food out of these tumor cells. And importantly, when we have these fusions, they can dimerize and lead to like ligand independent activation, which is really important. Otherwise, we do need ligands like FGFs that would otherwise activate this pathway. In addition to really understanding what we are talking about, mutations, fusions, amplifications, overexpression, we also need to understand which test we are using because there are different tests that can be employed. And what we have learned is that this detection of fusions is very challenging because we have so many different fusion partners. So we do need to employ a test that can detect the fusions independent of the fusion partners. And this is more challenging. It's a very busy slide and you can download it to see all the advantages and limitations. But what you can see on the left-hand side, we have NGS, broad molecular profiling, which we would definitely recommend because only with this we can really have an fusion partner independent detector of the fusions. We have amplicon-based approaches, we have PCR, we have FISH, and we have immunohistochemistry. Immunohistochemistry we would not recommend for fusions. Also FISH I would not recommend. It is a method, but with that we would only detect the fusions, not all fusions. And we would not detect all the other genetic alterations. So I would not go for FISH. What we would recommend in general are NGS-based approaches with the new tests which are available at the moment would have a very high likelihood that we can really detect these fusions. And we have already briefly discussed on the use of liquid biopsy as a potential option to detect these FGFR2 fusions. And what you can see here, on the left-hand side, we can definitely use liquid biopsies in cholangiocarcinoma. Not all of them are shedding the DNA, so you may not find anything. And then when you look at the likelihood that you detect your alteration, you can see the overlap for IDH1 mutations, which are very simple hotspot mutations. So most of them occur at the same region. You have a very good overlap between liquid biopsy and tissue-based analyses. When we now look here at the fusion, then this is specifically for the first generation of tests that have been employed, that it was really difficult to detect these fusions in liquid biopsy because we have so many different fusion partners. I think the more recent tests that have been employed, you can see that the concordance rate is much higher now, getting close to 90%. But here it's really important that you talk to your molecular pathologist which tests are employed both for tissue and for liquid biopsy if you need to use liquid biopsies. We have now seen efficacy, interestingly, compared to IDH1, where we do have a phase 3 study. For FGFR2 fusions, we only have single-arm phase 2 studies. Nevertheless, 3 drugs made it into the NCCN guideline, and you can see here fludarabine, pemigatinib, and erdafitinib. And here you can see all the other alterations which we have or will discuss later on. So we have, and at the moment we would think the most frequently used drugs are fludarabine and pemigatinib. Here you can see the data which basically led to the approval of pemigatinib and fludarabine. Here for pemigatinib, that was the first phase 2 study that we conducted. We observed a response rate of 35%. As you can see here, the majority of patients really are responding, and we achieve at least a disease control, and there are hardly any patients that have a primary resistance. Same picture for fludarabine. It's always difficult to do this cross-trial comparison without a control arm to put it a little bit into perspective, but you can see that the efficacy data are very similar, and it is a question to which of the drugs may be more effective, because now we have 2 drugs, like the same for durvalumab and pembrolizumab, which were maybe even more similar than pemigatinib and fludarabine. So having option is good, but you also need to make decisions which of the drugs you are using. And you can see here that the efficacy rates are very similar, and it's really hard to tell from this cross-trial comparison whether either of the drugs would be more effective than the other. These are the most recent updates we provided. We have now, you can see a median follow-up of 45 months, duration of response over 9 months, response rate increased to 75%. So it's really good to see that we can achieve nice responses in these patients. And these are all patients in the second and third line treatment. So these drugs are effective, and importantly, this is not an artificial clinical trial population. Also, when we look at real-world data, and we do see now more and more real-world data, that these efficacy data are reproduced here. In this study, for example, with 120 patients, you can see that we are even achieving a response rate of almost 60%, and the disease and PFS is very similar to what we have observed in the FIGHT-202 study. So here we really have a nice match for real-world data and the clinical trial data we have seen, which is also supported by the very consistent effects we have observed with all the different drugs which are available today. At ASCO this year, just to highlight this poster, this is again, I think, a study from the US with 50 patients treated with fludarabine and 55 with pemigatinib. You can see the baseline characteristics are very similar, and we have to look up this poster and see whether and how the efficacy data for this real-world cohort were. We have already discussed before that there were 3 studies in the first-line setting to really explore the efficacy of these FGFR inhibitors to the standard of care. At that time, it was GEM-CIS. Unfortunately, none of these trials really were fully recruited, and they were all stopped because of the very slow recruitment rate, and also the detection rate of FGFR2 fusions was a little bit lower than we have expected when we first published the data in the second and third line setting. One of the studies which is still ongoing, or some of these studies are like ongoing but modified. So the Phoenix CCA3 study is now the CCA4 study. And here we want to explore what is the best strategy and the best dosing of these patients. And 2 doses, fludarabine 20 milligram and 60 milligrams, are compared, and this study is still ongoing. What I have already mentioned a little bit, so we usually do see this, we do see nice responses, we do see very high disease control rates, but we have also learned that these responses are not really lasting for years. And at some point, unfortunately, secondary resistance develops in many, if not all, patients. And we do need to understand how this secondary resistance evolves in order to overcome it, of course. And I think here the FGFR targeted therapies are a good example on to show what we have learned over time and how we can really use these information for further developments. And here, and this is a really nice work that was published by Lipika Goyal at the end of last year. We have now not only in clinical trials, but also in the real world setting, that we are trying to understand why are these patients not responding to the FGFR inhibitors. And what we need to do for that is to do rebiopsies at the time of progression. And again, here we could use either tissue-based biopsies or liquid biopsies to understand, in many cases, this polyclonal resistance. And what we have learned is these are the FGFR2 fusion protein. Again, a very busy slide, but I just want to highlight that we have here the kinase domain. And what we have observed that many of these secondary resistance mutations occur in this kinase domain. And we have here two types of alterations, the gatekeeper and the molecular brake, which both have in common that the drugs cannot bind anymore to the fusion protein, and with this, they are not active anymore. And some of these alterations also have intrinsic activity or lead to activation of the fusion protein. And then what we have learned is we have here now these first-generation reversible inhibitors like pemigatinib or the irreversible inhibitors like futibatinib. And you can see there's a lot of overlap, but they also differ a little bit. Yeah, and specifically with these reversible first-generation inhibitors, we do see a wide variety of alterations after treatment, and a little bit less here with the irreversible inhibitors such as futibatinib. And this offers, and this was very early clear, that this offers us the opportunity for sequential treatment. And what we do see now is that there are a lot of companies that are investing in newer generation FGFR inhibitors. And the idea is first to be more specific for FGFR2, so not FGFR1, 2, 3, 4 anymore, and that these new drugs also have efficacy against these on-target resistance mutations, because then they allow us basically to use these FGFR inhibitors sequentially. So first generation FGFR inhibitor, for example, in second line, and then we move on to a second or newer FGFR inhibitor in third line. And these are examples on how this looks like in clinical trials at the moment. So we do see that they're more specific, like the drug from Relay, for example, they are more specific for FGFR2, and they do have activity against the on-target resistance mutation. Yeah? So here you can see a couple of these on-target resistance mutations, and in red means that we do, at least in vitro, we do not see activity anymore with a specific drug when these resistance mutation occurs. And then for Relay, for example, you do see more green, which means more activity also against these on-target resistance mutation. And the first data have been published, and we do see a very similar efficacy of these second and third generation FGFR inhibitors as with the first generation inhibitors, but we can apply them sequentially. And this is another example like tinangotinib, for example. Again, here it's getting more green. Yeah, so high activity against these on-target resistance mutation. And here you can see this cartoon, I think, quite nicely. Here you can see the fusion protein, the inhibitor, which needs to bind into this pocket. And if you have this on-target resistance mutation, the drug cannot enter this pocket anymore, and the drug is not effective anymore. And with these newer FGFR inhibitors, they can still bind also in the presence of these on-target resistance mutation, and this basically allowed this broader activity profile also against patients that have been pre-treated with FGFR inhibitors. And this is depicted here. So data for tinangotinib, you can see in inpatients that have been pre-treated with FGFR inhibitors, very nice responses here, up to 50-60%. And this is also something what we do see in clinical practice when we treat our patients, rebiopsy, understand resistance mutation, and then sequentially treat them with these newer drugs. And this not only means that we do see responses, but it also translates in a longer survival. So that I think is very exciting and offers new opportunities. And here we indeed have a phase 3 study. And I think it's good that we have phase 3 studies. And it's also nice to see that we can conduct phase 3 studies in this third line setting, if you like. So patients have been pre-treated with an FGFR inhibitor, one of the approved FGFR inhibitors, which would be pemigatinib or futibatinib. And then they are basically randomized either against physician choice, against tenigotinib with 2 different doses. And here in the expansion part, they are basically compared against physician choice. And I think this first 308 study is a very interesting study, and it's recruiting. And we do see more and more FGFR inhibitors. So sometimes I think there are more drugs than patients. I do see in my clinic. And I just want to highlight 2 examples because they also have started their programs now. One is the drug from Tyra 200. And you can see again, it's a lot of based on in vitro assays. And you can see here again the different drugs and here the activity against the different on-target resistance mutation, which I have shown you before, these gatekeeper and molecular brake alterations. And for Tyra, you can see we do see a very high activity also in the presence of these on-target resistance mutation. And actually the same here for the drug from Cogent. I think that are 2 very interesting drugs which are currently tested in phase 1 studies, and probably we will see more data on sequential treatment of FGFR with FGFR inhibitors. And at some point, we hopefully will also get to a point where we do get not only deeper responses, but also longer lasting responses. But to do that, we probably also need to move to combination therapies as we have seen it for the IDH1 inhibitors. Of course, when we talk about efficacy, which is very convincing, we also need to talk about toxicity. And one of the most frequent side effects we do see is the hypophosphatemia in patients treated with FGFR inhibitor, which is basically an on-target effect of this drug. And in most cases, and I will come back how to treat that. And one side effect which may be more concerning are eye toxicities. Again, I will discuss a little bit more in detail. And the third side effect I think we need to mention are the skin toxicities that can occur in these patients. Yeah. So also having here a case of a patient that's an unresectable cholangiocarcinoma, had upfront GemCis immunotherapy, standard of care, but progressed unfortunately after 6 months. And then the patient developed, or the NGS testing was performed, and an FGFR2 fusion was detected. So what does it now mean for our patients? So how would you treat these patients? Maybe also when we think about the sequential treatment, or which options would you take? I think it's a little bit more difficult to decide between pemigatinib and futibatinib compared to durva and pembrolizumab. So how would you treat the patient at the moment?
I think it is challenging. I mean, they're both active. They both have a reasonable response rate for the disease. The preclinical data is a little different, one being reversible, the other irreversible. I think it comes down to access. How is it going to be covered by the insurer, particular regions of the world? I think that there's data, at least also, that futibatinib could be used in certain resistance settings. So, I think you could really choose either. I don't know. What do you do? Do you have a go-to, or how do you think about this?
Yeah. I'm really undecided, and it's not an easy decision. I think if you have both drugs available, and I really like this approach of sequential treatment, yeah. But of course, you do not really have a guarantee that if you start with pemigatinib, that you get the right on-target resistance mutation that you can treat with futibatinib. This cross-trial comparison, I mean, numerically, it seems to be in favor of futibatinib, but I'm not really sure that we can draw here definitive with very small numbers without a control arm. Yeah, so I think I don't have yet a clear strategy. I like this sequential approach. I tend to think that futibatinib may be more active, but it's not good evidence. And having tenigotinib at some point, I think that would be really helpful, because then it doesn't really matter anymore whether we do PME or futi, right? And then we could go to tenigotinib. So what do you do in your clinical practice?
Yes, if I would have the opportunity to treat with both drugs, probably I will start with pemigatinib and then futi, just in order to see if there's a chance to have responses. If I have only one chance,
you take.
then it's more difficult. Yeah.
Yeah. So in terms of side effects, and maybe we can discuss this a little bit more in detail. So for the phosphate, I think it's something we need to measure. I think most of my patients are still in the range of grade 1 or 2, and I usually just recommend a low phosphate diet and phosphate binders. There are more recommendations such as phosphoruric agent to increase phosphate excretion when you really have high levels of phosphate. I personally never stopped treatment because of high phosphate, right? So,
And I think one important point here is if you mentioned the rest of the side effects are really affecting the quality of life of the patients, but really hyperphosphatemia, it's never affecting the quality of life because it's completely asymptomatic. So you have only to measure it and to control it. But for me,
I agree with you.
I'm not worried about that.
And I think sometimes you run the risk of overcorrecting it and having hypophosphatemia.
and the clinic require.
I think for most patients, it's the dermal toxicities that are most relevant that require. Well, I use a multidisciplinary dermatologist to help.
Yeah, I fully agree. I mean, so maybe the ocular toxicity should be mentioned. I mean, in the beginning, we talked a lot about the retinal detachment, which sounds scary, I think. Yeah, but honestly, we have seen it very rarely, and it was always reversible. Some of our patients have this blurry vision, but many of my patients didn't really have any retinal detachment despite having blurry vision. So you can have some ocular toxicities, but in general, if not in all cases, it is reversible. And the skin toxicity James mentioned before, I think that's really something that has clearly an impact on the quality of life of our patients. And I think that also needs to be openly discussed because specifically in patients that are longer on the FGFR inhibitors, really most of them develop, not all, but many of them developed skin-related side effects from stomatitis, dry mouth to the nail and skin toxicities. And there are a lot of recommendations, and I think here we don't need to go into all the details, but patient education is really important, providing like kind of care kits so that they're prepared for that. And with that, we can manage the side effects. And again, surprisingly, sometimes it looks really like debilitating sometimes even, right? But patients still tend to continue with the treatment. So there's sometimes, I think, a disconnect between what we see and what the patients experience. Yeah, but this is definitely something we need to discuss with our patients. So maybe some questions also here about molecular testing. NGS FISH immunohistochemistry, I think, are you doing this FISH immunohistochemistry at all?
No, I'm using NGS and then sometimes a reflex like RNA panel. Yeah.
I think it's important to perform a wide panel because there's a lot of targets that we have to test. You don't know if your patient will be IDH1 or FGFR or whatever, BRAF. So you need a wide panel and to test for all the potential targetable alterations.
So then here's another question, which I actually intended to ask you. And this is basically, so when do you perform your testing? And would you rebiopsy your patients after failure of treatment?
I think that given the landscape, this is going to be a reasonable thing to do for FGFR2. I do. I also think you could employ cell-free DNA as a non-invasive modality as it can detect some of these mutations. But I do think this will be important with the landscape moving forward.
But today it's true that it's not changing the treatment. I mean, no, if you have some limitations in the NGS analysis, it's true that to repeat the NGS analysis today in the majority of patients don't change your treatment. No? I am doing it more for a research purpose, probably that for, but yeah.
So maybe just briefly, one last question here. What do you think about co-alterations? I think that's a very important question. And when we do this broad profiling, we do get not only our target alteration, but also the co-alteration. And the question is to which extent that these co-alterations really affect the efficacy of our drugs. So far, it's not 100% clear. We do have some indications that depending on which FGFR inhibitor you're using, if you have p53 alterations or CDKN2AB alterations, responses are a little bit lower, but also we know that these are subgroups that have a really bad prognosis and worse prognosis. Yeah, so sometimes I think it's really hard to distinguish with these single-arm studies what is really causing resistance to the treatment versus what is basically a poor prognostic factor. So at this point in time, I would not change my decision-making based on the co-alterations. I heard some different opinions on that, but do you do it in your practice?
I have not, though I have heard that some consider TP53 perhaps futibatinib based on some of this, as you stated, data. So I think it's a provocative idea.
Okay.
All right.
Coming to our last time.
All right. So I'll bring it home. So we'll talk about HER2. Very briefly, I mean, HER2 is one of the HER family members, receptor tyrosine kinase, and it's unique relative to the others in that it doesn't have a known ligand. And when it's activated, it's forming a heterodimer with one of the other EGFR family members. This initiates signaling. And so the key thing here is that we know that a variety of solid tumors are driven by HER2, the protein, and ERB2, the gene. This is a bona fide oncogene for which there are multiple cancers that now derive benefit from its targeting. And in cholangiocarcinoma, you have a few different ways there can be alterations in this pathway. One which is uncommon is missense mutations in various aspects of HER2, right? The other is genomic amplification, which may ultimately translate to overexpression of the HER2 protein. And so in cancer of targeting HER2 now, there are a number of potential ways you can target this pathway. The initial form of targeting HER2 was really with monoclonal antibodies that bound to the extracellular domain of the molecule, leading to inhibition of HER2 signaling, ADCC, internalization, and were transformative in breast cancer. Another potential approach is actually small molecules that can interfere with the tyrosine kinase domain. Another more topical approach are ADCs, antibody-drug conjugates, which are simply antibodies that have a linker and carry a chemotherapeutic warhead. And then more recently, bispecifics that target two separate epitopes of HER2 and have unique mechanisms of action. And so kind of the high-level summary of this is HER2-targeted therapy works in biliary tract cancer. First, of course, you need to detect it, and the modalities which you could certainly use would be NGS to look for amplification. You can use immunohistochemistry to look for overexpression of the protein, and if it's equivocal, a reflex FISH or ISH analysis to see if there's a co-occurring amplification. I think one of the key lessons, though, is that it's really important, the overexpression by immunohistochemistry as an important predictor of response as we're learning in this disease. But I just want to walk through this slide very briefly. For single nucleotide variants, so missense mutations, you see this 1 to 5% of biliary tract cancers. There is single agent, very modest anti-tumor activity for neratinib, a TKI, as well, TDXD, and also even trastuzumab and pertuzumab. The issue here ultimately is response rates are low, duration of response is short. That may have to do with the clonality of HER2 missense mutations. They're often subclonal in biliary tract cancer. And what we found in the neratinib basket study is that subclonality across tumors was often associated with a worse outcome and short response to treatment. So this is still investigational. There are ongoing TKI studies that are evaluating this. The real meat of treating biliary tract cancer now deals with overexpression by IHC3+, or IHC2 with amplification. There have been a number of studies that have looked at this. The initial ones were baskets with trastuzumab and pertuzumab that had led to a 25% objective response rate in a small patient population. There's a subsequent study recently published in the JCO from Tauper, similar size, a response rate of about 30%. We've also seen the combination of trastuzumab with TKIs in a basket study, high response rate there. The two which we'll focus on for this evening, given that both of these now are ongoing phase 3 studies in biliary tract cancer, are the bispecific zanidatamab and the ADC trastuzumab deruxtecan. And so at the present time for biliary tract cancers, there are 4 NCCN guideline-based approaches that could be used. Really, the more modern therapeutics is zanidatamab, trastuzumab deruxtecan, trastuzumab pertuzumab, and dacotinib trastuzumab. And so I'll first start with zanidatamab. So this is a bispecific antibody, as I said, and essentially there's an asymmetry in the antigen binding domain, which leads to unique functional properties. It binds to 2 separate epitopes on HER2, and ultimately this leads to a trans binding phenomena which cross-links HER2 on the cell surface. This, in the preclinical models, almost forms a cap, which then activates ADCC. It also leads to degradation of HER2 and impairment of HER2 signaling. And in preclinical models, this was superior to combinatorial monoclonal antibodies like pertuzumab and trastuzumab. This is a sort of novel approach. A phase 1 study initially looked at a number of tumors. There was a 20-patient cohort of biliary tract cancers where there was an observed 40% response rate, which prompted the Horizon BTC01 study. This was a global open-label phase 2b study that essentially took patients with biliary tract cancers that had to have HER2 amplification by a central ISH test. And then those patients underwent further immunohistochemistry testing and were placed in one of 2 cohorts. Cohort 1 was the HER2 positive cohort, so IHC 2 or 3+. Cohort 2 was the IHC low or negative 0 or 1+. Then went on to receive zanidatamab intravenously every 2 weeks. The primary endpoint was objective response rate by an independent central review, and then key secondary endpoints included duration of response, disease control, PFS, OS, and safety. And so the study ultimately demonstrated that the objective response rate for cohort 1, which was the cohort of interest, was 41.3%. By the independent review, and similarly for the investigator. Here's the waterfall plot indicating tumor shrinkage in about 60+% of the patients, color-coded by anatomic subsite, illustrating that anti-tumor activity occurred in all anatomic subsets of biliary tract cancer. The key finding, I think, is a long duration of response, but is really in the subset analysis for this trial, which is that the 3+ patients really did much better, 51.6% response versus really 5% for the 2+. And I think this has now been seen with other agents, as we'll see. And in updated data from this clinical trial that was presented by my colleague Shubham Pant from MD Anderson, last ASCO, we showed the updated survival data for this. So the median overall survival for the cohort 1 was 15.5%, which is favorable, I think, in a heavily pretreated patient population. The IHC 3+ 18.1 with IHC 2+ here at 5 5.2 months. So clearly an important biomarker. Tomorrow we'll have a poster illustrating the concordance of IHC-ish with cell-free DNA from the screening for this clinical trial. So we screened almost 800 patients globally. And essentially what we identified is that if you're IHC3 plus, about 94% of patients will have a genomic amplification, but not all. 6% did not. And in the amplified component, about a third of amplified patients are not IHC3 plus. So I think it's very important that we really are looking at IHC as a marker for selection for these treatments, and more importantly, understanding heterogeneity amongst all of this. You can also detect HER2 in the cell-free DNA, but the concordance is lower. Another important, I think, interesting poster that will be presented by my colleague Richard Kim is a real-world experience of zanidatamab. This is from the abstract, and I encourage you to go to the poster, really showing a similar median overall survival for the compound relative to the clinical trial in comparison to other chemotherapeutics. In general, zanidatamab has a favorable safety profile, typical of when you target HER2. You may have GI toxicity, diarrhea. This drug may cause an infusion-related reaction, typically grade 1 or 2, manageable with rechallenge and lowering the rate of infusion. Other toxicities that are of interest but uncommon would be cardiotoxicity, cardiomyopathy, as can be seen with HER2, but very uncommon. And of course, diarrhea. So you just have to be mindful that this can be managed with antimodals, and there are established guidelines here. So I think we're doing a polling question now. I don't see the question, but if you want the $50, please just answer the poll. I want you to have more polling for mine than the others, okay? All right. So the important point, though, as we move beyond that, is that given the, I think, very favorable data for zanidatamab, a global phase 3 study, Horizon BTC 302, now has been launched, really assessing the patients with advanced biliary tract cancers that are HER2 positive, allowing both 2 and 3 plus, randomizing 1-to-1, basically a GemCis immunotherapy versus GemCis immunotherapy and zanidatamab, with the primary endpoint of PFS, particularly in the IHC3 plus. Other endpoints will include overall survival, safety, as well as assessment of the IHC2 plus. Critical ongoing trial, which is enrolling. The other compound that I wanted to discuss was the ADC trastuzumab deruxtecan. Really, I think, going very well with what we saw with zanidatamab from the Destiny Pan-Tumor02. Looking at TDXD in a number of solid tumors. Here's the biliary tract cohort, smaller but similar findings. You basically see enrichment in the IHC3 plus, whereas the IHC2 has limited response. The responses, though, remain durable, 8.6 months. This compound also has a favorable safety profile, more akin to a cytotoxic in that you may see cytopenias. You also have the potential of GI toxicities. Rare but serious pneumonitis may occur, which must be surveilled and monitored. The key point here is this too has also moved into the front line in the Destiny BTC01 study. This is also a large randomized phase 3 study that is assessing TDXD in multiple fashions. First, as monotherapy relative to GemCis Durva, and then as a novel immune combination with rilvegostomig, the PD-1 TIGIT bispecific. This here is looking here at overall survival in the IHC 3+. So this is an important study as well, addressing a slightly different concept. So I think we're almost at time, but back to the case, really IHC 3+. How do we go about doing this, knowing that there are multiple options? How do we determine what to do? So I guess now I get to ask you, what do you guys do? What do you think, Arnd, Teresa?
Yeah, I mean, so if you find someone who is HER2 positive, of course, you aim for HER2 targeted therapies, right? So I can hardly imagine, and this is also one of the questions here for the FGFR2 fusions, once we do get these alterations, there are hardly any hard contraindications of employing them. There are no clinical pictures or co-alterations where we would say no to the targeted therapy. Here it's getting even more complicated in IDH1 we have one drug or maybe one in development. For FGFR2 fusions we have this sequential treatment, but the same scenario is also here for HER2.
Yeah,
we have learned in gastric cancer that the ADCs, the trastuzumab deruxtecan, they also have, because of their chemo activity, have also activity in second line, right?
correct.
So we can also think here, even if it's not really yet approved, about employing this sequential strategy. So I think these data from zanidatamab are very compelling, right? It's a large cohort. It's very clear that we would target the IHC 2+. And for me, also keeping the sequential approach in mind, the tucatinib data are also interesting, but probably at this point I would start with zanidatamab, and then I would rebiopsy, and if the patient is still positive, I would try trastuzumab deruxtecan and second HER2-directed therapy.
Yeah, I think zanidatamab in second line is a very good option, and it's so very well tolerated in monotherapy. So we'll see what happens in first line in the clinical trial in combination, but monotherapy in second line is so well tolerated. Right. So there's no contraindication.
The real answer would be we shouldn't have these patients because they should all be going on the first these studies. So we have to identify. Yes. We have to answer this question. Yes. All right, that's the rule.
So, but yeah, maybe one other question also. I mean, in terms of combination, I think combinations are very interesting.
Yeah,
we do see these combinations now for the HER2 targeted therapies. For FGFR2 fusions, they have been mainly tested as monotherapy. I think also due to toxicity, when we combine targeted therapies, they have never really been combined with chemotherapy, to be honest. We have done a clinical trial and used it in combination with immunotherapy, and hopefully we can report these data in later this year. So atezolizumab and daraxontinib, which was also an FGFR inhibitor, that have been tested in BTC. So I think these IO combinations are definitely interesting, but we have to wait and see how the data are. In terms of whether we need to retest our patients, if we have done the testing very early on, I think we probably do not need to retest. These driver alterations are usually very stable over time, and even if they are diagnosed at the time of resection, for example, if you have recurrence a year later, you can retest, but you don't need to retest most likely. One question for you, maybe, James, in terms of you have mentioned it a little bit with the ctDNA and the immunohistochemistry, but in terms of, is it enough to do NGS? Do we need to do HER2? Should we do both?
I think that I personally think we really have to continue to do HER2 IHC as well, because I think you come to the poster, there are a subset of amplified tumors that do not have high IHC expression, and that seems to be an important biomarker for response. I think that it's very interesting that in other diseases 2+ will respond to HER2 targeted therapy, but biliary tract cancer is not entirely the case, and I'm concerned it has to do with just heterogeneity in this 2+ subset, and I think that's yet to be determined. But I personally, and what we have been doing, would be to reflex HER2 IHC now with ISH, but also send for NGS to be comprehensive for this disease and this specific treatment.
And in the first visit, because you have to include the patient in clinical trial.
Yeah.
So you have to do it.
I do it really early.
Well, and maybe also one question about the HER2 1+, 2+. I think for the monotherapy and second, third line, we don't really have good data. Actually, not at all.
Not at all.
Yeah. So probably we should not treat them.
No, I agree with that. I think that that population 1, 2 plus 0, 1, this low subset, I think it's a worthy to explore that with perhaps combinations and understand better this pathway.
Yeah. So in first line, they are not excluded, right? So in combination with chemo and immuno, they are not excluded from the trial. So we will get more data for these patients.
They are excluding 0 and 1. So 2 plus, 2 plus,
yeah.
With ish though. Yes, exactly.
Positive. So
Yeah, have to have it.
high expression.
So
probably I think the low expression, probably we have to go like in gastric cancer. No, this is not breast cancer, and they are trying to in clinical trials. So if we have the possibility to include these patients in clinical trials with these strategies of
with, I think, combinatorial strategies.
Why not? Maybe in the future.
I agree with that.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Cholangiocarcinoma Foundation. This activity is supported by independent medical education grants from Incyte Corporation, Jazz Pharmaceuticals Incorporated, Servier Pharmaceuticals LLC, and Taiho Oncology Incorporated. To access all materials for this activity, visit peerview.com/VZA860.